Good evening, everyone. Welcome to tonight's Lung Cancer Living Room. Happy to have all of you here. Everyone in the room, those of us joining online, welcome, welcome. We're so excited tonight to have Dr. Jacob Sands from Dana-Farber. Some of you may remember Dr. Sands was here a couple of years ago speaking with us at the living room, so we're more than thrilled to have him back. He's going to talk to us a little bit about, not a little bit, a lot of it, about something we touch on at most living rooms, but we don't really, or haven't in a while, given a full living room meeting attention to. And I think it's one of the more important things that we need to talk about that directly relates to each and every person in the room in some form or fashion, right? So clinical trials, what they are, what the different types are, what the different phases are, why they're important, not just from a treatment standpoint, but what other types of studies and trials are available out there that you can participate in to help move the needle forward in this space. So we're super excited to have Jacob here with us tonight. And with that, I'm going to I'm going to make a comment about Dr. Sands first, then I'm going to ask him to introduce himself and talk a little bit about why or where he came from, how he got into lung cancer, and why it's important. But what I will tell you is the very first time I met Dr. Sands was at a conference in Southern California, and he became like my soul brother immediately. We, to the whole family, actually, we were all in this like a, I don't know, like a bus that took us to dinner after the conference or something, and we just absolutely connected. And I just want to reiterate what my sister Andrea said about him. Not only as an amazing physician and oncologist, but an amazing human being. So with that, who are you?
So my name is Jacob Sands. I'm a thoracic medical oncologist at Dana-Farber. So I really treat people just with lung cancer. That's the only diagnosis that people see me for. And my disclosure is I absolutely adore the entire Addario family, Addario organization. The feeling has been very much mutual from the first time that I met them. And I'll say professionally, when I see people, I think the aspect of what goes on for an individual that within the medical field we do not adequately address is that social isolation that I think a lot of individuals feel. They get diagnosed with something, as Barb said, they get told a million things that they should do, they shouldn't do, and I try and warn people about some of that too, because I think a lot of people are trying to be very helpful. It comes from a very good place. They're told all the things they should do, all the things they shouldn't do. Many times there's conflict between what one person said and what another person said, and so you kind of get bombarded with this information that you don't quite know what to do with, but sometimes people also just act differently. They don't know what to say. They don't know how to interact with you. And so I watch people start feeling somewhat lonely with the diagnosis as well. Even sometimes while people really are rallying around them, I think that there can be a feeling of that. So a setting like this, to have an organization like this, I just think there's tremendous value in that. And I'll acknowledge that I think as a medical field, although we really try and take care of the entire individual, the entire family, this can be an aspect that is more difficult within our setting as opposed to a setting like this. So thank you all for doing all that you do. So I did my training at UC Davis up the road in Sacramento. I was there for 7 years before then moving to Boston because my family is on the East Coast. So I was choosing between Boston and New York City, and Boston to me was a clear choice. So I've been there now for 6 years. I started out at Leahy, a hospital there that's more of a community center that does academic work, thinking that I really wanted to be in a setting with less of the bureaucracy, and found that bureaucracy on the other side is actually infrastructure. And so for the clinical trial stuff that I was trying to do, I needed that infrastructure to support some of the other stuff I was doing, so then I'd no longer call it bureaucracy, which was a good shift in my perception of things. So I've been there for a year now, focusing really on small cell lung cancer, has been my real focus. I lead our clinical research program in small cell lung cancer. That being said, I still write trials within non-small cell. I still see a lot of people within non-small cell as well. So kind of the spectrum. But it's an absolute pleasure to be here with you tonight.
So thank you, Jacob, for the introduction and talking about, sort of where you came from and what you're doing now. With that, we're going to jump right in. And if you wouldn't mind starting with something that we started this conversation with tonight, which is the different types of clinical trials. There's a lot of misnomers about clinical trials, which I want to kind of get through tonight. But I also, a lot of times there's a tendency for people to think that they're just strictly treatment trials available as opposed to some of the other things. So can you talk a little bit about the difference in some of the trials?
Yeah, so if I can, though, just start out with a couple of really just the basis of clinical trials and something that is absolutely at the foundation of what to know about trials. Because I think a lot of people come in with very different ideas of what trials means, and I see people who come in very familiar with trials and very interested, and I see others who come in extremely skeptical, insisting they don't want a placebo. And that is kind of an older way of looking at trials, although placebos do still exist. So I kind of want to start from there. Any trial being discussed for an individual is being discussed as a best option for that individual. Yes, we can move the field forward. Yes, we can learn more and treat people in the future better. But that trial is not being discussed with any individual other than to help that individual. And anyone here who is on a trial or a trial is being discussed, it doesn't matter what happens for people generations to come. It is about what is going to help you. Now, hopefully that drug helps and is good and becomes a new standard of care and therefore helps a lot of people. But nobody goes on a trial to help everybody else, not a treatment trial. It is about, and you are allowed and should be very selfish about any treatments you're going on. I say that across the board. When someone is talking with their doctor about a treatment to go on, that is 100% about what will help that individual. And that's the basis for everything. So that is an absolute truth that I think people don't necessarily come in with understanding. Now, there are other aspects that can be, hey, is it okay if we collect an extra tube of blood? Is it okay if we do other analysis on tissue that had been previously biopsied? Or in some cases, is it okay if we do a new biopsy because we're trying to gain better understanding? Those aspects can be absolute giving to science. A blood sample or a biopsy that's not necessarily going to guide an individual person's treatment options can be. But as far as what treatment drugs that are being chosen, that is 100% about what's going to help that individual. And really, we utilize trials as a way of finding a better way of doing things than what we have now. So that being said, if it's a first line, so someone gets newly diagnosed and a trial is being discussed, that is going to have, at a very minimum, the best known treatment option. That's true for all scenarios, but especially when it's first, that ends up being a lot of different options typically. So you're looking at that plus something else, or something that also has been proven. So at any of these, it's doing, at a minimum, the best of the current standard, and then looking for something better, hoping that that something better works even better for that person. So to kind of go through some of it, though. So there are different phases of trials. So phase one, this is phase one is first in human testing. This is after it's been tested in a lab and been really impressive in petri dishes, tested in mice or sometimes even in other animals, and been very promising in those settings as well, where the drug is working extremely effectively and the toxicities are minimal. And it really has to be not borderline. It has to be very clear, very exciting in those settings to even go to phase one testing. Phase one testing is we have a whole bunch of data from petri dishes, from mice, and so forth to guide how much drug we think we need. But since it's being tested in humans for the first time, we need to really test and see what kind of toxicities come about, what kind of level of drug is tolerated, and that is started at a low dose. And frequently there's a mechanism for, and it can be different in different trials, of essentially enrolling people onto this drug in a setting where it will hopefully help them as well. But we're starting at a low dose, and we're going to work our way up to see how it's tolerated. If it gets to a level where people are having side effects, then it gets dropped back down a dose, and that's how we find what is the dose that's really tolerated.
Can I ask a question?
Yes.
How long does a phase 1 trial typically last? Does that vary also?
It varies a lot, and it depends on what you're treating. So there are some that are for anyone who has a solid tumor, colon, breast, lung, all of that. They can be enrolled onto this study if they believe that that drug seems like it may be effective for all of those different populations. Then they enroll, and that may enroll faster than something that, say, is for a more rare kind of a cancer.
What type of number of patients are usually on a phase 1 trial? Or does it vary greatly too?
Well, it varies, but I mean, certainly depending on how many ultimately end up getting, how many levels you go to before people are having side effects. But for the most part, I'd say it's very common to enroll 3 and then see what the side effect is like for those 3, and then enroll another 3 after you've seen that that's been well tolerated. Now, there are some others where they will enroll more than 3 in a dosing cycle.
All right, phase 2.
So phase 2 is taking something where in the phase 1 we say, okay, this is the dose that we're choosing. And there's a lot that goes into that. We've discussed a little bit. And we say, okay, this is the dose, and then we expand it out and say, okay, we're going to enroll, it can vary, 50 people, it can be more, at this dose of this drug or multiple drugs, and then we're really looking at effectiveness. So phase 1 is tolerability, finding the dose that works, but hopefully people really get benefit from it. I mean, that helps guide what we expect from the drug, is we want to see people doing well. Phase 2 is saying, okay, we've decided on the dose. This is the optimal dose, and let's see how well it works in this situation.
At what point do you determine whether or not that might be the best option for a patient? Same question as phase 1.
That is always at the heart of what you're doing to begin with. So anytime you have somebody on a trial, it is because you think that that is more likely to benefit them than standard treatment.
Okay, so you said with the phase 1s that's more likely sort of a, we've sort of gone through standards of care, phase 3 trials. So you go from like a phase 3 to a phase 2 to a phase 1. Like, what is that?
It can be. You know, there have been drugs in phase 1 that have been really exciting. Don, I think at the very beginning, either Don or Ron at the very beginning had mentioned Loxo 292. You know, I'm not, you know, well, I'll say that was an exciting phase 1. And so that's one that there was data reported at this last ASCO that was very exciting. And so there can be these earlier phase studies that really are exciting. Now that is more an exception to when these really stand out. But it depends on the situation.
And how, same question that David asked earlier, how many patients typically enroll in phase 2 trials?
Phase 2 can vary a lot. And you know, we'll see phase 2s done in a variety of ways. There can be phase 2s that are really a first look at effectiveness, where it's a smaller number of people enrolling, and we see randomized phase 2s that are really more like a small phase 3.
Can you explain randomized?
Randomized is where there is a math to it, where randomization can be done in a few different ways, whether it's 1-to-1, which is common, or 2-to-1. But say if there are 2 different arms to a study. So the small cell study that I mentioned just a minute ago, where it was chemotherapy versus chemotherapy plus Keytruda. So 2 arms. Well, we don't get to choose what people go on. There's a whole math to, we send in a number that represents a person, and they put that into a system, and it spits out which treatment they're getting. And then we have to do that treatment. And that randomization is done to try to make sure that both sides are being treated, that both groups are essentially the same. So, you know, So let me take a step back, actually, in how we even come up with these treatments themselves, how we know anything about these treatments themselves. Now, when I went to medical school, I thought, oh, you go to medical school, and in those 4 years, you learn everything. And when you come out, you just do a test. It tells you what they have, and you do the treatment that works for it, and bang. And I learned that it's like the rest of life. it's really balancing probabilities. You're balancing risk versus benefit when someone comes in. Now, sometimes it can be very clear-cut what's going on, and other times you're saying, well, gosh, a common story actually of people I see with lung cancer, they went to their doctor, they had a cough, and their doctor said, oh, you've got an infection, take this antibiotic. And that doctor was right for 99 people, but that one person had lung cancer, and that was what was causing it. But they go by probabilities of it. And then, well, the antibiotic's not working, so okay, let's get a chest x-ray, and now something shows up on the chest x-ray, and they say, well, gosh, that still looks like it could be infection, and you did get better on the antibiotic at first, so let's do more antibiotic, because that also works for the majority of other people like that. But in the end, it turns out it was lung cancer. Well, see, you're also not going to do a CT scan and a biopsy on everybody, or else you're going to be biopsying a whole bunch of people with pneumonia saying, why'd you put me through that? And so a lot of this is balancing risk and benefit and looking at a situation and saying, So really the best way to analyze how a drug works and what side effects would come from it would be if we could take 100 individuals and somehow have those 100 people walk both paths. Does that make sense? Where we can say, well, this person, you are the exact same person living the exact same life, and on this path, this happened, and on this path, that other thing happened, and so that's the difference. But obviously, we can't do that. So the randomization is an effort at trying to make sure that each side is essentially equal. The number of people that got radiation to the brain is the same on both sides. The number of people who are living without any symptoms versus the people who are having some symptoms is essentially the same between the two groups. So there are certainly situations of phase 1 that we find the dose and things look promising. Phase 2, and again, looks promising, and then a big phase 3. And this is where I had mentioned earlier that sometimes there's a kind of a phase 2 that's a small phase 3. Mm-hmm. And phase 2 can really range the most. It can be small, just single arm, get a sense. It can be actually fairly big, randomized 2-arm or more study looking at a comparison. And I think certainly for companies, they benefit the most from getting drugs out and FDA approved as quickly as possible. So they're certainly trying to push that. And we see companies where the drug worked and we say, oh, well, they did this kind of this phase 2 that took a while, and then they go to this big phase 3. They should have just done a bigger study from the beginning. And then we see others where it's the exact opposite, where they do a big study and then things aren't effective, and we say, oh, they should have been more careful and gone slower in the process. And so retrospectively looking back is how we determine whether they did the right thing or the wrong thing, but it can be hard to know going forward.
I think it's important to note, and maybe this is not in all trials, but definitely some trials, even if they don't move forward for the patients that it is working for, sometimes they're still allowed access to that drug that's working for them, right? Even if the trial fails.
Yeah.
But talk a little bit more about the phase 3 and maybe kind of how they do take that final step towards approval.
Yeah, so phase 3s are really where, so the really big studies, the randomized studies, where we're saying this is the experiment, we say experimental therapy, but the experimental arm being the treatment that we're studying compared to best standard of care, best care you would get off a trial, and comparing those. And the bigger studies are really typically a phase 3. Now phase 3, so it can be a registration trial, which is saying that we are planning to use the data from this trial for the purpose of getting FDA approval. And not every phase 3 is that, but the one, and there have been phase 2s that have been that as well, but more typically it's within phase 3s. So the phase 3s are the ones that have really gone through the most testing for the most part. Now, this process, we're describing it in this stepwise manner, and there is kind of that pathway, but it doesn't look the same for every drug. So some drugs have gone phase 1, phase 2 FDA approval. For example, crizotinib, which was already an approved drug, but for ROS1, which is a much more uncommon cancer, with a phase 2 that was enough for it to then be approved. And others have gone through to more than 1,000 people in a phase 3 study, so that can vary individually with each drug.
One of the things I've heard over and over again now, and it's come more recently than maybe 3 years ago, is, again, the nomenclature around clinical trial and the language itself. The concept of clinical trial, because of this long history of placebo, or in some communities, the things that had happened in those communities, it's a detriment to people being open to a discussion. The use of the term experimental drug, right? Are there ways that we, as a community of lung cancer people, could we rethink that language and really maybe call it a clinical study versus a trial? And I understand it might not make its way through the medical community, and going away from maybe calling it an experimental drug to the prospective drug, or something different that might get people to look at this a little bit differently and be more open to a conversation versus the negative connotations that come around experimental and trial.
And I think this goes hand in hand with what we talk about when it comes to palliative care, calling it supportive care, right? Like separating supportive care from hospice care instead of lumping it all into one just palliative care conversation.
I mean, it is, it's such a complex topic.
It is.
In general, as you know. And as I said, when I see people in clinic, where they're coming from in their perspective around clinical trials, and sometimes I'll start with kind of trying to untie some of what are the common misconceptions out there. And there are people that go, oh, okay, that's great. There's not a placebo. It's and others that go, why are you even saying these things? Because some people come in with these preconceived ideas and some don't at all. And so, I mean, it's great that you're doing stuff like this, because I think there are so many misconceptions out there. I still want to make sure everyone leaves here with the understanding that any clinical trial is being done because it's thought to be the best option for that person.